In this lecture, we'll be discussing about optic neuritis. Okay, now optic neuritis, it refers to the inflammation of the optic nerve. So again, the definition: optic neuritis, it includes the inflammatory and the demyelinating disorders of the optic nerve. Now the etiology: it may be idiopathic in most cases. It may be in the form of hereditary optic neuritis, which is seen in Leber's disease. It may be associated with the demyelinating disorders like multiple sclerosis or neuromyelitis optica, also known as Devick's disease. It may be in the form of para-infectious optic neuritis, seen in viral infections like measles, mumps, chickenpox, whooping cough. It may be in the form of infectious optic neuritis, seen in syphilis and TB. It may be associated with autoimmune disorders like sarcoidosis, systemic lupus erythematosus. And finally, it may be in the form of toxic optic neuritis, which is due to poisons like tobacco, lead, arsenic, and cannabis. So again, the etiology: the various causes of it, optic neuritis may be idiopathic. It may be hereditary optic neuritis, also known as Leber's disease. It may be associated with demyelinating disorders like multiple sclerosis, neuromyelitis optica. It may be in the form of para-infectious optic neuritis, infectious optic neuritis, or also seen in autoimmune disorders like sarcoidosis or systemic lupus erythematosus, and finally in the form of toxic optic neuritis. So this is the etiology. Now moving on to the clinical types. Now the optic neuritis, it can be classified into three anatomical types. First is papillitis, second is neuroretinitis, and third is the retrobulbar neuritis. Now papillitis, there is involvement of the optic disc in inflammatory and demyelinating disorders. Neuroretinitis, it is the combined involvement of the optic disc and surrounding retina in the macular area. And third is the retrobulbar neuritis, that is involvement of the optic nerve behind the eyeball. So again, the clinical types, we have three types: papillitis, mainly involving the optic disc; neuroretinitis, involving the optic disc and surrounding retina in the macular area; and third is the retrobulbar neuritis. Retro meaning behind, bulb referring to the eyeball, hence involvement of the optic nerve behind the eyeball. So these are the three clinical types. Now coming to the symptoms. Now optic neuritis, it may be asymptomatic or associated with the following symptoms, which are: the first is the vision loss. Now monocular, sudden, progressive, profound visual loss is the hallmark of optic neuritis. Second is the presence of visual obscurations in bright light. Now obscurations refer to transient loss of vision which lasts for a few seconds. The third symptom is that there may be episodic transient obscuration of vision on exertion and on exposure to heat, and this recovers on resting and or moving away from the source of heat, and this is known as Atov's symptom. Okay, so we have visual obscurations in bright light and transient obscurations on exertion and exposure to heat. The fourth symptom is the impairment of color vision, and the patient complains it as reduced vividness of saturated colors. Fifth is the dark adaptation, which may be lowered. Sixth, the depth perception of moving objects is impaired, and this is known as Pulfrich's phenomenon. And the final symptom is pain. There may be mild dull eye ache, and it is more common in retrobulbar neuritis. And such pain, it is aggravated by ocular movements, especially in the upper and downward directions. So these are the symptoms. Now a simple mnemonic to remember the symptoms is LP-DOC. Now L stands for vision loss. Remember, monocular, sudden, progressive, profound visual loss is the hallmark of optic neuritis. P for pain, mild dull eye ache, which is common in retrobulbar neuritis. D for two things. First is that the depth perception of moving objects is impaired, and this is also known as Pulfrich's phenomenon. And the second is that the dark adaptation may be lowered. Now O is for visual obscurations, and this may be seen in bright light or on exertion or exposure to heat. And C is for color, impairment of color vision. So these are the 7 symptoms of optic neuritis. Now let us discuss the signs of optic neuritis. So we've discussed in the symptoms that there is visual loss, and hence the first sign is that the visual acuity is reduced markedly. Another symptom we discussed is that impairment of color vision, and this is the second sign, and this is typically there is a red desaturation, that is the patient sees red as washed out or pinkish or oranges in color. Third is the presence of Marcus Gunn pupil, that is the relative afferent pupillary defect is positive. Next is the ophthalmoscopic findings in optic neuritis. Now the ophthalmoscopic findings are different for papillitis, neuroretinitis, and for retrobulbar neuritis. So let us begin with the ophthalmoscopic findings of papillitis. Now this is the clinical picture. And from this you can notice that there is hyperemia of the disc, there is blurring of the margins of the optic disc, then the disc appears edematous, the physiological cup is obliterated. So this here is a physiological cup, and you can see that it is obliterated in papillitis. The retinal veins, it appears congested and tortuous, and splinter hemorrhages and fine exudates may be seen on the disc. So these are the features of papillitis. So again, hyperemia of the disc, blurring of margins, edema of the disc, physiological cup obliteration, the retinal veins appear congested and tortuous, and splinter hemorrhages or fine exudates may be seen on the disc. Now a point to note is that the disc is edematous. Okay, another condition in which edematous disc is seen is papilledema. Now to differentiate papilledema and papillitis through ophthalmoscopic findings, in papillitis it really exceeds 2 to 3 diopters. That is, to view the disc clearly you need to increase the power of the ophthalmoscope. Okay, so in edematous disc, to view the disc clearly you need to increase the power of the ophthalmoscope, and for papillitis you need to increase it up to 2 to 3 diopters, whereas in case of papilledema you have to increase the power of the ophthalmoscope up to 3 to 6 diopters to view the edematous disc clearly. So these are the features of papillitis. Now coming to neuroretinitis, here the inflammatory signs are also present in the surrounding retina. Okay, and the papillitis, it is associated with macular star formation. So this here shows the macular star formation. Now this peculiar feature is due to the deposition of lipid exudates along the outer plexiform layer of the macula. So in neuroretinitis there is basically features of papillitis along with macular star formation. Now in retrobulbar neuritis, the fundus appears normal. Remember, the retrobulbar, that is the optic nerve behind the eyeball, is affected, and hence the fundus usually appears normal, and this condition is typically defined as a disease where neither the ophthalmologist nor the patient sees anything. In some cases, temporal pallor of the disc may be seen occasionally. So again, the ophthalmoscopic findings: in papillitis there is hyperemia of the disc, blurring of margins, disc edema, physiological cup obliteration, the retinal veins are congested and tortuous, and splinter hemorrhages and fine exudates are seen. In neuroretinitis there are features of papillitis along with macular star formation, and in retrobulbar neuritis the fundus appears normal, and the typical feature is that the ophthalmologist and the patient cannot see anything. Now the next sign is the visual field changes. Now the most common visual field defect in optic neuritis is the relative central scotoma. 6 is that the contrast sensitivity is impaired. If we remember, the depth perception of moving objects is impaired, and this is a symptom of optic neuritis, also known as Pulfrich's phenomenon. Here contrast sensitivity is impaired. Now visually evoked response shows reduced amplitude and delay in transmission time. So this picture here depicts visually evoked response. Then fundus fluorescent angiography, it reveals mild to moderate leak in the early phase. Now a mnemonic to remember the signs of optic neuritis is shove your best friend. Now S stands for scotoma. Remember, a relative central scotoma is the most common visual defect in optic neuritis, and S also stands for splinter hemorrhages, which may be seen on the disc. H is for hyperemia of the disc. O for obliteration of the physiological cup. V stands for veins, which appear, the retinal veins which appear congested and tortuous, and V also stands for visually evoked response, which shows delay in transmission time. E stands for edema of the disc and exudates on the disc. B stands for blurring of the margins of the disc, and F for fundus fluorescent angiography, which reveals leaks. Now of this, the signs which are marked in orange refer to the signs of papillitis. Okay, now remember, if signs of papillitis along with macular star formation, it is indicative of neuroretinitis, and if the ophthalmoscopic finding is normal, that is the fundus appears normal, it is a sign of retrobulbar neuritis. So again, the signs of optic neuritis, remember, shove your best friend. S for scotoma, central scotoma. S again for splinter hemorrhages. H for hyperemia of the disc. O for obliteration of the physiological cup, which we saw in this diagram. Obliteration of the physiological cup, this is the normal physiological cup. Then V for the veins which appear congested and tortuous. V again for visual evoked response which shows delay in transmission time. E for edema of the disc. Remember, in papillitis it rarely exceeds 2 to 3 diopters, whereas in papilledema it is usually around 3 to 6 diopters. The second E is for exudates on the disc, B for blurring of the margins of the disc, and F for fundus fluorescent angiography. And those in orange are features of papillitis. If there is, along with this, if there is macular star formation, then it is a feature of neuroretinitis, and if the fundus appears normal, it is a feature of retrobulbar neuritis. Next is the differential diagnosis for optic neuritis. Now, if the features of papillitis are present, then it should be differentiated from papilledema, ischemic optic neuropathy, and pseudopapilledema. Now, if there are features of acute retrobulbar neuritis, it should be differentiated from cortical blindness. So these are the differential diagnoses, that is papilledema, ischemic optic neuropathy, and cortical blindness. Next is the investigations to be done for optic neuritis. First is the multifocal VEP, that is visually evoked potential. Now this is helpful in making early diagnosis of optic neuritis. Second is MRI scan of the brain and orbit. Now the optic nerve MRI scan, it reveals swelling of the optic nerve, and in brain MRI white matter lesions may be seen. Now if vision deterioration continues after 4 to 6 weeks, then other causes of optic neuritis must be investigated. That is, remember the etiology: infectious, autoimmune disorders, para-infectious optic neuritis, etc. Now the prognosis of optic neuritis. Now there are 3 types of prognosis. It may be evolution, recovery, and complications. Evolution refers that the visual acuity and color vision is lost progressively over a period of 2 to 5 days. Okay, so we have the first is that the loss of visual acuity and impairment of color vision progresses over 2 to 5 days. Second is the recovery phase. Now here visual recovery, it starts within 2 weeks and takes about 4 to 6 weeks, and this is the most likely outcome in 70 to 90% of the cases. So we discussed evolution and recovery, and remember, recovery, it starts within 2 weeks and it takes about 4 to 6 weeks. Next is the complications. Now if there is recurrent attacks of acute retrobulbar neuritis, it can lead to optic atrophy, and if there is recurrent attacks of papillitis, it can lead to complete blindness. So this is the prognosis. Remember, evolution, recovery, and complication. Evolution is that within the first 2 to 5 days there is progressive loss in vision and impairment of color vision. Recovery starts within 2 weeks and it takes about 4 to 6 weeks, and this is the most common prognosis. 75 to 90% cases of optic neuritis recover. And complications. Now if there is recurrent attacks of papillitis, it can lead to complete blindness, and if there is recurrent attacks of acute retrobulbar neuritis, it can lead to optic atrophy. Now coming to the treatment of optic neuritis. Now first is the treatment of the cause, that is, you find the cause and you treat the cause. Second is corticosteroid therapy. Now this is done to shorten the period of vision loss. Now you've done the investigation and the MRI shows lesions supportive of multiple sclerosis. Now such a patient is immediately administered with IV methylprednisolone, okay, 1 gram daily for 3 days, followed by oral prednisolone 1 milligram per kg per day for 11 days. So this is the treatment if the MRI shows multiple sclerosis. That is, immediate administration of IV methylprednisolone followed by oral prednisolone. Now IV methylprednisolone, it can also be given for acute optic neuritis in the following cases. That is, if there is vision loss in both eyes simultaneously, when the only good eye is affected, and when there is slow progressive vision loss which continues to occur. Okay, so the second mode of treatment is corticosteroid therapy using IV methylprednisolone, and this is given immediately if the MRI scan reveals presence of multiple sclerosis. And IV methylprednisolone can be given for acute cases where both vision loss is there in both eyes, or when only the good eye is affected, or when there is slow progressive vision loss which continues to occur. And the third mode of treatment is interferon therapy, and now this helps to reduce the recurrence in patients, but such therapy is expensive. So again, treatment, we have treatment of the cause, corticosteroid therapy using IV methylprednisolone, and interferon therapy. Now this completes our discussion on optic neuritis. So a quick revision: we discussed optic neuritis. It is the inflammatory and demyelinating disorders of the optic nerve. Then we discuss the various etiology like hereditary optic neuritis associated with demyelinating disorders, infectious optic neuritis associated with autoimmune disorders, and toxic optic neuritis. Then we discuss the clinical types, that is papillitis involving the optic disc, neuroretinitis which involves the optic disc and the surrounding retina in the macular area, and the retrobulbar neuritis where there is involvement of the optic nerve behind the eyeball. Then the symptoms, remember the mnemonic LP DOC: L for vision loss, P for pain, D for depth perception is reduced, and lowering of the dark adaptation, O for obscurations which are seen in bright light and on exertion or exposure to heat, known as obtuse symptom, and C for impairment of color vision. Now remember, if depth perception of moving objects is impaired, this is known as Pulfrit's phenomenon. So these are the symptoms of optic neuritis. Then we discuss the signs. Remember the mnemonic: shove your best friend. S for central scotoma, which is the most common visual field defect seen in optic neuritis. H for hyperemia of the disc. O for obliteration of the physiological cup. V for venous congestion and visually evoked response which shows delay in transmission time. E for edema of the disc. Remember papillitis 2 to 3 diopters and papilledema 3 to 6 diopters, and also presence of exudates, E for exudates. B for blurring of the margins of the optic disc, and F for fundus fluorescein angiography which reveals leaks. Along with this, there is visual loss, hence there is reduction in visual acuity, and there is impairment of color vision, and there is Marcus gun pupil, that is relative afferent pupillary defect is positive. So these are the signs. Then we discussed the differential diagnosis, that is papillitis must be differentiated from papilledema, ischemic optic neuropathy, and pseudopapilledema, and acute retrobulbar neuritis should be differentiated from cortical blindness. Then the investigations, multifocal visually evoked potential is helpful in early diagnosis, MRI scan of the brain and orbit, and if vision deterioration continues after 4 to 6 weeks, then other causes must be investigated. Then the prognosis we discussed, that is evolution, recovery, and complications. Remember evolution, vision loss and impairment of color vision continues for 2 to 5 days. Recovery starts within 2 weeks and takes about 4 to 6 weeks, and it is the most common prognosis in 75 to 90% of the cases. And finally complications, if there is papillitis, it can lead to complete blindness, and retrobulbar neuritis can lead to optic atrophy. Then we discuss the treatment modalities. The first is the treatment of the cause. Second is the use of corticosteroid therapy using IV methylprednisolone, and finally interferon therapy.